So I'm going to try to do a bit of a high-level overview on the interoperability and standards mechanisms that can help to exchange information between organizations like hospitals using certified electronic healthcare products and CBOs. And my disclosure is that I'm the volunteer board chair of HL7 International, which is an international standards development organization, and led a bunch of this work. First, I always like to give just a few words about community health centers. Health centers were an outgrowth of the civil rights movement and designed to create culturally competent healthcare access in places in which healthcare access was very disparate or didn't exist. And that practice continues today. Health centers have 5 essential elements. They're located in high need areas. And for the last 60 years or so, since the health center program started, they have always offered enabling services, which is an older term for what we now call social interventions, so transportation, food, housing, those kinds of things. And they're open to all residents regardless of their ability to pay. They're governed by members of the community, which means they're aware of and responsive to patient community needs. Health centers actually serve in 1 in 11 people in the United States. That's probably far below the need that's still unmet in healthcare. But because we serve these patient populations that lack healthcare access otherwise or have underinsurance or uninsurance status, those people are more likely to have these social needs be unmet. So I wanted to start by not talking about challenges in CBO, SDOH, and HSRN data, but rather talking about that in the EHR space. So electronic health records, despite being required to use standards for data exchange, pretty much all are developed based on proprietary schemas, models, and content, which means that all of that information has to be mapped by someone to an exchange standard as it comes out of the EHR in the data warehouse. And that process results in issues with the validation of the data in the EHR, lower data quality, a lot of missing data, variance in where people document things. So you might find that the same bit of information can be seen in several different places in the record. Lack of harmonization of requirements of different agencies, reporting structures, and individual health organizations is a big barrier to success because it creates more data inconsistency. And it really is a low to no value add on the technical teams that are responsible for managing this data. Many EHRs don't have very good dashboarding and data extraction tools, which means it can be hard for those organizations to get good information out and share it. And a big missing link in the EHR programs is difficulty or lack of support for right to capability. So as we talk about closing the referral loop, pushing that information back into a place where a user can interact with it may be difficult to impossible without some significant effort. I'm sure I'm preaching to the choir on why we would collect standardized data on HSRNs and SDOH. But when we do that at the individual level, it allows us to group that information in many ways. We can look at health disparities in different populations. We can understand small pockets of the community differently from other pockets of the community. We can look at the needs and also the amount of services delivered to different people at the local health system level. We can integrate payment patterns with the health data of the patients themselves. And of course, we can use that information at a high level to talk about state and national policies and where we're starting to meet the mark and where we're still really missing it. So this is the United States core data for interoperability. These are the foundational elements that certified health records need to support for electronic health records. And since the 3rd edition, right now they just closed comments on draft version 5. But since the 3rd edition, SDOH health assessments have all been supported. ONC recently released a rule earlier this year stating that EHRs should be in the process of updating and recertifying to support for all of these elements. The one challenge with support for these elements is if you look at what it says under many of these categories, it's not something highly specific. So it doesn't say use this assessment or tool. It says do SDOH data capture, do SDOH data goals, but it doesn't give you a lot of guidance on how to do that. And the challenge becomes, as you decide how to do that for your organization, you should not really expect that that necessarily aligns with how other organizations do it. So that requires coordination, which is relevant to the use case we're talking about here. Which vendor is your organization working with? What assessments do they support in the record? How are those coded? And can you receive those in a standardized way that is meaningful? So I use Prepare here as an example. Prepare is a standardized validated instrument developed between NAC and the Asian American Pacific Islander Community Health Organization, APCHO, to be designed by people who do this kind of work with patients, and to be designed by patients to understand what some of the sort of early emerging HSRN and SDOH needs were. And the ones that you see here often are already, may exist in the EHR. They're sort of required elements. And then you see several of the primary SDOH domains that many programs start with. Prepare is in an update to 2.0, but it is coded in LOINC, meaning that it should be supported by certified electronic health records. And because it's widely used in all the different EHR systems, it can be a good way to normalize this kind of information and to get some sort of useful insight on what the patient's needs are. And as I said, it's a standardized tool and it's patient-centered. NAC frequently talks with health centers about how to connect the things that they do at the assessment and patient-facing end of their work with these opportunities to generate billing and payment. So one of the methods to do that is using Z codes. These are ICD-10 CM diagnosis codes that can be linked to the assessment results, and then they'll become a member of the problem or health concern list in the record. These may be easier to use because billing codes are generally more extractable from electronic health records than things like assessments. So this could be a sort of a first step if you're looking at how do I get the first look at whether or not one of these needs has been identified. Of course, the organization needs to have worked out a workflow to generate these Z codes as part of the billing record if you're going to extract them. If the health organization relies on a mindful person to re-enter this information as a billing code, that's going to be less complete and accurate than it will be if the assessment result automatically generates one of these codes and puts it into that problem and billing list. There are also, as many of you probably know, new codes that have been released for people like community health workers to do these kinds of assessments, but there are rules about how those need to be linked to encounters. So really thinking through what that workflow looks like in terms of, are we able and authorized to bill for any of this activity? How do we generate a valid code that could be billed? There may be an opportunity actually to work with organizations like community health centers to do some of this work as well and generate a payment sharing arrangement if that's not something that your organization can support based on the providers and kinds of encounters that you do. But something to think about, because we know of organizations that are using Z codes increasingly, and it's often sort of a point of entry in terms of data exchange because of the ease of getting those diagnosis codes in and out of systems. I always like to emphasize, although this is probably the last audience that needs to hear it, that just doing the coding for the needs does not address the needs, right? So we need to focus really also on robust ways of coding the activities that we provide to the patients to meet their needs. One of the things that's, sort of an increasingly well-known finding in the field is that, 97% of data in some systems never gets looked at again. So we can do assessments all day long, but if it doesn't trigger an action, then we are unlikely to have served the patient. And we're also unlikely to learn what kinds of services for what kinds of patients are actually meeting their needs. If we see that we do the assessment, we find the need, we do the referral, we refer the patient, they come back and the need is unmet, we need to be asking ourselves, why is that? And we need to really be looking at those data and saying, okay, taking this referral action is not generating an impact for these kinds of patients. What is the other thing that we can do to support these patients? And as a person who sees patients as a primary care doctor in a health center, I see people come back not just for health-related social needs, but also for medical needs when they get a referral and they have not taken the action. And there are many barriers that they experience as to why. Sometimes it's really just a lack of support and understanding of what the action that needs to be taken is. Sometimes it's an issue of, I can't take time off work, I don't have transportation, all of this, I don't have to tell you, but I think it's important for us to emphasize this part of the picture when we work with health organizations, because I think this is less well recognized in many traditional medical contexts. So I'm going to talk just for a little bit more nerding out about standards. So FHIR stands for Fast Healthcare Interoperability Resources. The goal of FHIR is to sort of make electronic health records and health data exchange more like data exchange on the internet, to sort of release information into small packets that are easy to go in and search and find, and then pull them out, the information specifically that you need, so that then you can act on that without having to get big documents full of vital signs and other things that you don't need. It's very easier for programmers to use because of how similar it looks to the standards we use on the internet. And so even a relatively, junior kind of software engineer often finds, oh, I know how to do this, I can figure this out. So as you think about having a technical team and a technical approach, you definitely want to look at FHIR, because a FHIR API was required to certified products on December 31st, 2022. There'll be an update, as I mentioned earlier, on the version of that which is required to be used in EHRs, but basically all the EHRs should have already deployed this to their customers. And certainly at the hospital level, we know that happened faster than it did in the outpatient side. And FHIR is also the basis of the Gravity project. I know that we had looked into having one of the Gravity project leads give a talk on this today, so I wanted to make sure I covered some of that. So FHIR Accelerator is a community of people who are all brought together around a use case. And the Gravity Accelerator includes many folks from CBOs, community health centers, hospital organizations, also some payer and regulatory participation. And the goal of the Gravity project is kind of to pull together some shared understanding of what materials available for standards-based use in electronic health records and beyond, and to make that deployable in the context of where we are with EHRs and health IT data exchange. These are the 6 Gravity principles, data exchange principles for equitable health and social care. And I think hopefully they resonate well with this group, really trying to make sure that the patient and their outcomes are a primary focus and goal, and of course, preventing, reducing, and remediating harm. These are the current Gravity terminology domains. As many SDOH efforts do, they started with food, housing, transportation, but since have actually brought into a lot of important HSRN domains, I think, which are helpful and provide context to how we better serve these patients. Here's another set, as you can imagine: medical cost burden, coverage status, health literacy. Those things are all highly impacting whether or not people are able to successfully navigate a fragmented health system that really doesn't provide enough support for them. Part of what Gravity built is this implementation guide using FHIR, which is basically like a computer program or guide telling you how to share this kind of information, with the goal of generating a closed loop referral. You can ignore all of the terminology terms in here if that's overwhelming you, but the idea is moving from the assessment to coding of those things in the problem list, identifying the goals and proposed interventions, and then following that up with the quality measurement or dashboarding that's needed to really evaluate the success of the process. And this is sort of a flow diagram that shows how the information moves from place to place. I like to just briefly mention the care plan. So one of the core resources in FHIR is called the care plan. The care plan is organized by a health concern. So a health concern could be a diagnosed problem, but it also could be a health-related social need. So health concern is to be a big bucket that the problem list is a subset of. And the thing I love about the care plan is one of the first things it asks is, well, what's our goal here? As all of you know, just because someone has a health-related social need, it doesn't mean that they don't have specific goals that they would like to achieve in regards to that. Not every housing solution is acceptable to every person, and that is okay. It is not going to help us if we don't actually say what the patient actually is trying to achieve as we're thinking about how to address the concern. Then it asks us to, identify what are the interventions, care activities that we're going to pursue in regards to meeting this goal in this health concern. And then it looks for us to have a plan to evaluate that in the future. So I like this as a framework. And this is just an example of how we could share care plans across organizations to help address multiple kinds of issues with the patient at once. I wanted to call out risk stratification. Obviously, this is a high area of interest with ACOs and value-based care organizations. This is an example, and there is a link in here which you can look at, of how a team at a community health center in Ohio were doing creating a multidisciplinary team to figure out how to deploy and understand the risk model. Note that their high risk category was 7 or more social needs. So this is a high risk population with a lot of unmet needs. And I think thinking about, what you want to use as thresholds to trigger additional patient support is useful, because to the point that patients do still need that touch sometimes, especially if they're overburdened, you could use this kind of framework to do those identifications. So, I think of value-based care as leaving no person behind. And what we frequently hear from health center care teams is lack of follow-up on unmet social needs causes moral injury, both to the patient and the care team. So I think one of the arguments we need to make about investing in this infrastructure to support the teams and to do these transitions better is that now we won't be leaving these patients with these injuries and without the services that they want and need. And addressing fragmentation is really challenging, but it does have a negative effect on outcomes. We know that. So concerted effort to create coordination where fragmentation exists is really important. And I always like to point out to some of these higher resource organizations that they can talk about health equity a lot, but if they're not actively doing something to prioritize patients with these kinds of needs, that's equity last. So I just want to, re-emphasize again that dashboarding is really important here, not only because it helps you to demonstrate value to your ACO, but also because it helps your team to follow up on unmet needs, to understand what's working and what's not. And so I encourage you to create these health equity and care gap dashboards as part of the process where you're connecting with your partner health organizations to use that to drive the care. And if we're not looking at some of these intersections of health-related social needs, health equity, then we won't notice that a huge proportion of our trans patients, for example, report certain kinds of disabilities compared to other kinds of populations. So that's my last slide. I just wanted to leave you with sort of 4 thoughts. So CBOs need systems that can exchange data with other entities and trigger actions. That does not require having an EHR at all, because FHIR and the release of data in these non-information blocking kind of arrangements means you can use an HIE, a CIE, a social care tool, a data warehouse, an EHR. There are a lot of options available to you. So I encourage you to investigate what sort of the minimum viable product you need to do your work. Standardization of shared definitions is needed between those organizations. So I encourage folks to create a task force with their partner organization where they start by saying, okay, how do you capture this? How do we capture this? Is there a way to make that information flow back and forth and be usable in both places? If you're a computer and you see 2 things that are different, you won't put those things together. And so teaching the machines what's equivalent and what's not is important. SDOH reconciliation and follow-up. There are probably some great opportunities for AI to assist with this, and there are tools being, built and used now that help to pull additional SDOH data out of unstructured data and put it into a place where it can be acted upon. Those systems can also suggest actions. I always want to emphasize usability because it is very hard to work in this space right now. And the better we serve the care teams, the more effective they'll be at meeting these needs and filling those care gaps. And finally, encouraging people to think about integration of patient-generated health data. Even patients who are unhoused, who have relatively low letter of literacy, many of them have phones, either text-based phones or smartphones. I think 3/4 of health center patients have some kind of smartphone. And so we should ask people to tell us the information, enter it themselves, and then use that information to provide services to them. So thank you very much. Hopefully I wasn't too long. I'm looking forward to any questions we have time for.
Thank you so much, Dr. Skapik. We do have a couple, and I'm going to pose two of those together. They're both related to the Prepare tool. One is related to whether or not the tool also addresses other types of things, whether it's an add-on or other questions related to long-term care, such as mobility, intermittent care needs, and management. And then secondly, is there a reason for recommending the longer Prepare tool over the briefer CMS screening tool that covers 5 social risk drivers required by CMS? So whatever order you want to take those.
Sure. So I'll talk about Prepare first. So, we've worked with different organizations to do all sorts of different things with Prepare. Like we've worked with, a 2-person health center in the middle of Oklahoma to develop like a 1 to 2 question screener. So they didn't have to ask, 10 questions of every patient. And we've seen people who, go well beyond what's in Prepare. I think there has to be a point at which sort of your leadership and your care teams are engaged in what are the critically important things, what are the optional things, and how do we figure out who we need to ask which question to. We may not need to ask every question about intimate partner violence if that's deemed too burdensome, but we may want to ask every pregnant patient about that. We may want to ask every person with young kids about that. So thinking about what those use cases are and what the impact of those needs on care are can help to design intentionally a workflow that says, who are we going to ask which questions? Who are we going to ask all the questions? Who are we going to ask some of the questions? So I think that Prepare is sort of designed to be customizable in that way. And, there's a question on refugee status that, maybe the average hospital organization would not ask. But in many health center spaces, there's a large number of refugees and a lot of people who have trauma associated with their refugee status. So knowing those things can be helpful in meeting those folks' needs. In terms of an add-on or additional survey to Prepare, so I think that, there's a lot of ongoing work in the space of disability, functional status, in both the US CDI, those things have been proposed, but they're not sort of well described. The PASSIO project is a project very similar to Gravity that has done a lot of work in sort of the LTSS space. And it is also very patient-centered and strongly engaging the folks who do those long-term supports and services. I would encourage you to actually look at the content there and consider which items that describe functional status and long-term care needs would be the right ones to sort of add into your package. And then I think the last question was definition of community health center. So basically, NAC has member organizations. Most of them are FQHCs, but some of them are what's called community health center lookalikes. Community health center provides comprehensive primary care to people who have those to organizations that meet those 5 essential elements at the beginning. So they have to be led by a community board. They have to provide essential services. They have to be in high need areas, and they have to serve everyone regardless of their ability to pay.
And if you could answer this quickly, there's a question around the recommendation on how often to ask the screen questions on the clinical side. There are requirements for every admission. but how often should patients be screened, or how often are you? And then I think we'll move over to our case study.
Yeah, I mean, I think, in primary care, there's kind of an expectation that it's reasonable to ask people on an annual basis if they're not known to have needs. But I think for patients who already have identified needs, the follow-up needs to obviously be closer. We're trying to meet those needs and close those gaps. You would want to make, maybe a month or even less to follow up on whether or not patients are getting access to those services. It's just shocking how hard it can be to access something, even when sort of you are given access to it.
And I just want to point out, I think what we're hearing too is that there are some differences in the hospital and the non-hospital side, because there are the requirements for the hospitals to actually begin reporting out on the measures, which does require the capturing and logging and documenting of certain pieces of information to be able to do that. So we don't want to lose that point as well.
Yeah, and I can say I also work as a hospitalist, and I receive hospital documents from discharges. And it was only recently that I ever saw the entire blank page get populated in even one field. But I did see it, and that did come from an Epic system. It was for a whole year. I think I just had a blank page of SDOH questions coming through with the discharge summary. And now I'm starting to see, here are the answers to those questions, which is exciting. So a lot of this work has been a long time coming, and it's still slow getting here, but working with your partners to talk about what they have and what they can do, it maybe some of these things just need to be tested and turned on, is an important step in that process. So having sort of a little tiger team or a task force or something that works between the two organizations, and you can pull in other CBOs, don't need to do a one-off. But to work on the exchange of that information with some technical people and some like clinical and social care people is going to be really key in both developing those relationships, but also sort of getting that ball rolling.